Okay, good morning, good afternoon, good evening to everybody. Welcome to our special series of webinars on COVID-19 and topics related to early childhood development. Today's focus is on breastfeeding and newborn care, and we're really excited as the Early Childhood Development Action Network to be partnering with the Partnership for Maternal, Newborn, and Child Health to bring you this webinar along with the Nurturing Care Framework Coordinating Group with UNICEF, the World Bank, and WHO. My name is Shakufe. I'm with the ECD Action Network. Before we begin, just a few housekeeping things. One is in the chat, I encourage everyone to introduce yourself. Let us know what organization you're from, what are you doing, where are you joining us from. But please take a moment to select all panelists and attendees. So everybody right now, select all panelists and attendees so that everybody can be introduced to you. If you select only all panelists, then only the panelists can see your introduction, and we want everyone to get to know each other. We will begin the webinar with the speakers, and then it will be followed by the Q&A. However, during the presentations, we encourage everybody to type their Q&A in the Q&A box. If you type it in the chat box, we may miss it because there's so many messages that are going up and down. So if you type it in the Q&A, we'll be sure to respond to it. In the chat box, please feel free to share resources with each other, respond to questions that your colleagues have from around the world. We have over 1,440 people registered for the webinar from over 100 countries. So we welcome each and every one of you. Finally, in the Q&A, you can vote for questions. So if you see a question there that you have and you want it to be voted, then vote for a question so that it goes up and we can be sure to respond it. Please, if you see someone else has asked your question, don't repeat the question, but just vote for it. And you can also respond to your colleagues with the questions as well. All right, so without further ado, I'm going to introduce the Executive Director of ECDAN to give a few opening remarks. Over to you, Elizabeth.
Thank you, Shikufe. A warm welcome to the panelists and to all the participants on behalf of the ECD Action Network partners. We're delighted to be co-hosting this webinar together with the Partnership on Maternal, Newborn and Child Health that we work with closely on many things, especially the Nurturing Care Framework. This is such an important issue that we're addressing today, and it has come up through so many of our webinars, as COVID-19 has laid bare the challenges that young children and their families have faced, and especially those women who have delivered during this time, oftentimes all by themselves, in the efforts to contain the public health emergency. So they've been looking for support, materials, advice, and I think what we're discussing today is extremely important. For those of you who don't know the ECD Action Network, we're a global network, the youngest probably, of diverse partners and actors across the different domains of early childhood development. We catalyze collective action in the belief that together we're much stronger and can have greater impact. We're a global platform for knowledge sharing and exchange and learning. We also promote effective coordination across the partners and the different actors to develop global public goods. We also advocate for increased prioritization of early childhood development and also increase of investments to support young families, young children and their families. So I wish you good deliberations on this topic in learning from each other and the experts, and we welcome all the questions that will come up, and of course all the presentations will be shared afterwards.
Thank you so much.
Over to you.
Thank you, Elizabeth. And now I'd like to introduce you to the Executive Director of the Partnership for Maternal, Newborn and Child Health, Helga Foxted, for a few opening remarks. Welcome, Helga.
Thank you so much, Shikufe, and thank you so much, Elizabeth, panelists and participants. Warm greetings from Geneva, from the Partnership for Maternal, Newborn and Child Health, which is partnership over 1,000 member organizations across 192 countries and across 10 different constituencies. Every constituency from governments to private sector. And we also have a vibrant adolescent youth constituency that is taking on a lot of issues moving forward. The partnership is very focused on, has been very focused on the nurturing care framework and has been very occupied with issues related to empowerment, self-care and care-seeking behavior. We have focused on issues of advocacy, which is our strength in the partnership, and want to amplify key issues in importance, especially around COVID-19, where we have been putting together a resource toolkit with key topics that have been of importance. And so we have also this year done video together with WHO and partners on breastfeeding, which we will have made available to you, the link on the chat. Sheila will put it there. And we have also just wanted to share with you that we are also doing the economic analysis on empowerment as well as self-care, including breastfeeding. And so this is something that we would like to do in order to enhance not only the demand side, demand side creation, but also self-care and the importance of empowerment. And so this is something that we are also working on, as well as stillbirth and other newborn care issues, which we then have done with our partners. We are extremely excited to be collaborating with the ECDAN to respond to questions and concerns we have received from around the world on how to ensure babies and those who care for them get the support they need so that they are safe, healthy, and able to develop to their full potential. And this is our intent, and we look forward to this webinar. We look forward to being here with you. And please let us know what you think is useful and what you think is more needed, and let us know about that so that when we move forward, we are also in sync with that. Thank you from my side, and thank you from PMNCH. Over to you, Shikufe.
Thank you so much, Helga. Thank you both for this amazing collaboration. And now my co-organizer, co-conspirator, I hand it over to Sheila to take us through the first portion of the webinar. So over to Sheila.
Thanks, Shikufe. Welcome, everybody. Good morning, good afternoon, good evening. I just wanted to offer a bit of background before we jump into the speakers. But Ornella, you can start getting yourself ready. We put this webinar together because in discussion with the partners around the Nurturing Care Framework, so together with UNICEF, World Health Organization, and World Bank, we were noticing a lot of webinars around children and the impact of COVID-19 on children and particularly their development. But we were not seeing that many webinars focusing on our very youngest children, around babies in particular. And so we thought this was a place and an opportunity to really focus on the youngest children in our world. And then we were reflecting on questions that had come in to previous webinars hosted by ECDAN. And we were noticing that there were a lot of questions around the global guidance. What is the global guidance around breastfeeding and newborn care? And we were also noticing a lot of questions around what should be done, how should we be doing it? And so we thought, this would be an opportunity to really remind us all and make sure everybody is aware and familiar with the global guidance. And really offer a space where we could talk about what is possible, what is happening in different countries around the world. Today you'll hear from Vietnam, Brazil, and Colombia, but we know that you are coming from all over the world. So please, if you have solutions that you would like to share, strategies that are happening in your countries, please feel free to put them in the chat. We are interested, and everybody is eager to learn from each other on what is possible. So let's hopefully walk away from this webinar together with a common understanding around what the guidance is and what we should be doing, and then also some very tangible solutions for what we can be doing together to make sure babies everywhere get the best possible start in life. So let's start with the global guidance. We've heard your questions, and Ornella will take us through. Over to you, Ornella.
Thank you very much, and good morning, good afternoon, good evening to all of you. It's a pleasure for me to present on WHO guidance on breastfeeding and newborn care in the context of COVID-19. And I would like to start, if the presentation moves, sorry. It's a bit stuck, just a moment. Oh. I would like to start with reminding us the advantage of breastfeeding in terms of prevention of illness, particularly against infection diseases. And we know that the breastfeeding is also protecting from non-communicable diseases and from additional mortality even. And is also protecting mothers from breast cancer and probably from ovarian cancer and diabetes types 2, while improving birth spacing. So from what we know at the moment on the risk of COVID-19, we can say quite comfortably that the benefits of breastfeeding outweigh largely the potential risk of COVID-19. So far, in fact, the evidence shows quite uncertainty on the possible increased risk of negative maternal and neonatal outcomes. And there is no definitive evidence of vertical transmission of COVID-19. The few infants, in general, let's say infants are at lower risk of infection compared with older children or other age groups, people in other age groups, and the few cases that are confirmed COVID-19, newborns with COVID-19 to date have actually experienced mild disease or asymptomatic illness. So, and finally, so far, active particles of COVID-19 virus have not been detected in the breast milk, and it looks like the virus is not transmitted through the breastfeeding so far. And while we know that coronavirus can stimulate the production of immunoglobulins, and these immunoglobulins can pass in the breast milk and be protective, in fact. On the left side of the slides, you can see the the link to WHO guidelines and materials. So the recommendation that the WHO has developed based on the current evidence is that fundamentally mothers should not be separated from their infants, regardless of COVID-19 status, unless the mother is too sick for caring for her babies, of course. In this case, another competent family caregiver should be identified. And this no separation should be started from birth. So we recommend that mothers and infants should be enabled to stay together and practice uninterrupted skin-to-skin contact immediately after birth. And if the baby is born preterm or overweight, they can be allowed to practice, encouraged to practice kangaroo mother care as soon as possible after birth. And then mothers and babies should remain together while rooming throughout the day and night. So we know that breastfeeding can be interrupted either because the mother is sick or the baby needs to be admitted to the neonatal care unit. So what to do in these cases? In these cases, if the mother has severe illness that prevents her from caring for her baby or providing direct breastfeeding to the baby, she should be supported to express breast milk. And this milk should be provided to the infant while, of course, applying appropriate infection prevention measures. The mothers should, as soon as possible, should be supported to breastfeed if they were not given before the opportunity of initiating breastfeeding during the first hour after birth. And then finally, they should also assist to re-establish a supply, to relactate so they can continue to breastfeed, particularly when the baby is admitted in the neonatal care unit. Now we can have also the situation where the mother is so unwell that she is not able to breastfeed or express breast milk. And in this case, for a few days, and in this case, we have solutions. So the first option is to provide donor human milk, and this should be available from a human milk bank. We know that sometimes supplies at the moment could be limited because of COVID-19 restrictions and concerns. But in this case, we recommend to prioritize donor human milk for preterm and overweight newborns. And then if the mother, the second option the mother has is to use a wet nurse, which is another woman who is breastfeeding a child. So she might offer milk for this additional child. So this is an option that depends, of course, on acceptability to mothers and families, and availability also to wet nurses and support, both from the mothers and the wet nurses. And in these cases, if we choose these options, we recommend the screening of the wet nurse, but not a COVID-19 test if the woman doesn't have any symptom. And then we are also aware of situations where the wet nursing might be necessary in settings where HIV is prevalent. And in this case, we recommend, of course, that the prospective wet nurse undergoes an HIV counseling rapid test if possible. And if this is not available, at least to undertake an HIV risk assessment. So basically, the breast milk substitute should be used as a last option. But of course, because we are in the context of COVID-19, there are additional recommendations that for best practices in breastfeeding and newborn care that we want to highlight if the mother is COVID positive or suspected to be positive. So the first one is to perform a frequent hand hygiene with soap and water or alcohol-based hand rub, particularly before contact with the baby. The second is respiratory hygiene. So if she's coughing, to cough on a tissue, dispose immediately of the tissue and wash the hands. And then clean and disinfect the surface which the mother might be in contact with. And finally, very important, to wear a mask, a medical mask, until the symptoms are resolved. And but we know also that sometimes the masks are not available everywhere. So if the mother doesn't have a medical mask, she should still be encouraged to continue breastfeeding. She can wear a homemade mask, or she can simply breastfeed, because the advantages of breastfeeding are still much higher than the risk of COVID-19 for the baby. And again, still applying, of course, the infection prevention and control measures. And then we also recommend that we don't recommend that the breastfeeding mothers, for her to wash the breast every time she breastfeeds, unless she's coughing on, in that moment, when she's coughing on the chest, and in this case, she should be helped to wash before breastfeeding. And finally, we, as usually, I mean, this is valid everywhere, we, not only in the context of COVID-19, there should not be promotion of breast milk substitutes or bottles, teas, pacifiers, dummies, any part of facilities providing maternity and newborn care services. This is very important everywhere. You can see here also the icon of and the link to the video we were talking a moment ago. And then the last set of recommendations that I want to share with you is the care for small and sick newborns. And in case the baby is admitted in the health facility, we might, in the context of COVID-19, to have some adaptations. For example, it's important to ensure the parents are screened for COVID-19 before entering the NICU. They should be allowed to enter in the NICU, of course, but we would like to limit the number of caregivers to reduce overcrowding, and limit especially the caregivers providing Kangaroo mother care. So there should be 1 or 2 persons at maximum, and they should be trained in infection prevention and control and the use of the mask and washing, etc. And then we should also develop strategies to enable support to continue kangaroo mother care at home, because again, to reduce overcrowding in health facilities, we can consider also early discharge with follow-up of all the premature babies and overweight infants that are stable. And you can see additional guidance on two documents. One is on the one on maintaining health services, the operational guidance for COVID-19, and the second is the clinical guidance. So in summary, regardless of COVID-19 status, mothers and infants should remain together. They should be allowed to breastfeed, practice skin-to-skin contact and kangaroo mother care, and rooming day and night, while applying at the same time infection prevention control measures. This is, I think, is good for everybody. From the available evidence also, mothers should be counseled and encouraged, counseled that the benefits of breastfeeding substantially outweigh the potential risk of transmission. So they should be encouraged to breastfeed. And then finally, I would also to highlight the campaign, the Zero Separation campaign that will be launched in 2 days by our partners, the Global Alliance for Newborn Care and the European Foundation for the Care of Newborn Infants, which will help to support really the implementation, the dissemination of these recommendations for non-separation and breastfeeding in the context of COVID-19. Thank you very much.
Thank you so much, Ornella. Full of very important information, questions that have been coming in left, right, and center, and lots of resources. I hope everybody has been watching the chat on the side. All the resources that Ornella mentioned have been put in the chat. If you missed them, Pura will continue to put them in throughout the session so you can come back to them. And also when we send the recording of the webinar, we will also send all the resources also. So if you want to just concentrate on the conversation today and ignore the resources, that's fine. They will find their way to you. So let's turn now to, we know what the guidance is, but is the guidance being followed? What is happening in different countries? So I'm going to hand over to Jen from Alive and Thrive Southeast Asia, who will take us through an analysis of national guidelines or in 33 countries and tell us what's actually happening. Over to you, Jen.
Thank you so much, Sheila and Ornella. I'm very happy to be here today. My name is Jen Cashin, and I'm a regional technical specialist for Alive and Thrive based in Myanmar, but reporting today from Minnesota. So I'm going to share findings from a global review of national guidelines for breastfeeding and newborn care in the context of COVID-19. But first, just like to declare that I have no conflict of interest, but that I am a salaried employee for Alive and Thrive Southeast Asia. Alive and Thrive, just a bit of background. Alive and Thrive is a global initiative to improve maternal, infant, and young child feeding practices at scale. Since 2009, Alive and Thrive has evolved from at-scale implementation in 3 countries, Ethiopia, Vietnam, and Bangladesh, to now providing an evidence-based package of technical assistance to 5 countries and 3 regions. So since Ornella gave such a great overview of the WHO recommendations on breastfeeding and newborn care in the context of COVID-19, I'm just going to jump right into the methods of our study, then share some key results and conclusions. But before I begin, I just want to mention that we are currently preparing a manuscript on this research, which will be submitted for peer review soon. And the slides will be shared with you after the webinar. So we conducted an integrated review of guidance documents, an integrated literature review of guidance documents related to breastfeeding and newborn care in the context of COVID-19, with the aim of determining alignment with WHO recommendations. We collected documents from 33 countries between March 1st and April 30th, 2020. And if the documents were updated after that window, we did not include the updates in our analysis. And on the right-hand side of the slide, you can see the hierarchy of inclusion. So we first looked for national government guidelines on newborn care and breastfeeding. And if we didn't find those for that particular country, then we took state and provincial government guidance. And if that was also not available, then we included professional medical association guidelines from that country. So this slide shows the practices that we looked at. On the left-hand side, we looked at recommendations related to skin-to-skin contact, early initiation of breastfeeding, rooming in, direct breastfeeding, provision of expressed breast milk, provision of donor human milk, wet nursing, provision of breast milk substitutes or infant formula, and psychological support for separated mothers and infants. And on the right-hand side of the slide, you can see how we coded the recommendations. So we coded the recommendation as, we coded the practice as recommended, or V, if the guidance document was clearly supportive of that practice. We coded as not recommended if the guidance document clearly did not support that practice. And then there were some cases where the practice was allowed with certain conditions. So we coded this as X, comma, condition. So for example, in some guidance documents, rooming in for mothers and babies was allowed or supported, but only when mother's bed was 2 meters away from baby's crib. So that would be coded as X, comma, 2. And finally, if no information was provided on the practice, we coded this as 0 or absent. So now moving on to some key results. So we found that among the 33 guidance documents included in our analysis, less than 1/3 recommended skin-to-skin contact and early initiation of breastfeeding for mothers with suspected or confirmed COVID-19. So these are the green columns here on the left side and in the center here. You can also see from this slide that a significant proportion of guidance documents did not provide any information on these practices. So that's the dark green here. About half of the guidance documents did recommend direct breastfeeding in cases where mothers have suspected or confirmed COVID-19, along with appropriate infection prevention and control measures. Many guidance documents recommended separating mothers with suspected or confirmed COVID-19 from their babies, contrary to WHO recommendations. As you can see from this figure, about 30% of the guidance documents we reviewed recommended isolating mothers with confirmed COVID-19 from their babies, and about 12% recommended isolating mothers with suspected COVID-19 from their babies. A little over 1/3 of all the guidance documents we reviewed here did recommend rooming in, irrespective of mother's COVID-19 status, which is in line with WHO recommendations. A number of guidance documents also allowed for room sharing upon certain conditions, such as 2 meters distance or a plexiglass divider or curtain between mother and baby's bed. Most guidance documents did recommend the provision of expressed breast milk when direct breastfeeding was either not supported or not possible. Few, as you can see, guidance documents recommended the provision of donor human milk as an alternate feeding option, even in countries with human milk banks like China, Australia, France, and Brazil. This could be related to the fact that WHO, there are no global guidelines on human milk banking yet, and some countries do not yet have national guidelines either. No documents recommended wet nursing as a potential alternate feeding option. Most documents, about 80% over here, did not recommend the provision of breast milk substitutes, but about 20% did recommend the use of infant formula in cases where mothers had confirmed COVID-19. In this slide, you can see the proportion of guidance documents from low, middle, and high-income countries, which unequivocally support recommended breastfeeding and newborn care in the case of confirmed COVID-19. Low-income country guidelines were more likely to recommend skin-to-skin contact and early initiation of breastfeeding in line with WHO recommendations. One other finding I want to draw your attention to is on the right side of the screen. Only fewer than 1 in 4 or 1 in 5 guidance documents from low, middle, or high income countries included provisions for psychological support for mothers separated from their infants, and even fewer included psychological support for separated infants, which is really quite alarming given how traumatic such a separation would be. Just a couple of slides of discussion. To summarize, among the 33 guidance documents we included in our analysis, alignment with WHO recommendations on breastfeeding and newborn care was poor. Indeed, no guidelines followed all of WHO's recommendations, and none of the guidelines that recommended separating mothers and infants had any provisions for psychological support for mothers or babies, which is both alarming and also not justifiable based on infection control risk. There were also many gaps in guidelines, as you saw, leading health workers to make very difficult decisions. Finally, in considering why guidance documents made the recommendations that they did, sources of influence should be considered. On the right side of the slide, we've noted the most commonly cited documents by the national guidelines we reviewed. You'll notice that WHO guidance was cited in about half of the guidance documents we reviewed, followed by the US Centers for Disease Control and the Royal College of Obstetricians and Gynecologists. The US CDC guidance was quite widely cited, perhaps because it came out so early. But since it was initially released, that guidance has become much more supportive of mothers and infants remaining together and breastfeeding. In contrast, the WHO guidance and the Royal College guidance has not changed much since it was released. It's noteworthy that during the H1N1 epidemic or pandemic, the US CDC had a similar approach where a series of recommendations to isolate mothers and babies were made before these recommendations were later revised to become more supportive of breastfeeding. And this suggests that we need greater recognition of this approach by the US CDC in future infectious disease outbreaks. So the costs of impeding or preventing breastfeeding through recommendations against skin-to-skin, early initiation, and rooming in are likely to be significant and most keenly felt in low and middle income countries. Every year, an estimated 700,000 maternal and child deaths are attributable to not breastfeeding, along with about 1 million cases of childhood obesity and $340 billion in economic losses due to increased healthcare costs and cognitive losses. During infectious disease outbreaks, it is essential that the importance of breastfeeding and maternal and newborn well-being be considered along with the risks of disease transmission. But finally, just to note, our study did have some limitations. We did not include all the COVID-19 guidance documents out there, and they're being continually revised. So we acknowledge that our analysis may no longer be current. And in closing, I'd just like to thank the other authors for this study, Zung, Carlene, Kathy, and Roger, and thank you to all the colleagues and partners from the 33 countries who helped us collect and translate the guidance documents. Thanks very much. Over to you, Sheila.
Thank you so much, Jen. All right, so we've looked at the situation around the world. We know what we should be doing. We have a bit of a sense of what is happening and unfortunately not always in alignment with the guidance. But let's hear from some of the countries around what is possible, what are people doing and able to do to ensure continuity of services. Dr. Long, before I hand it over to you, just to remind everybody that you will receive the recording for the webinar, you will receive the slide presentations, you will also receive the resources that the panelists are sharing throughout the session. And if you have questions for any of the panelists, please do type them in the Q&A box. If you type them in the chat box, it's very likely we will miss them. So please type your questions in the Q&A box. And the panelists are monitoring, so they will be responding to your questions throughout the session, and then we'll also take some of those questions at the end when the presenters are done. So Dr. Long is going to take us to Vietnam as soon as he's able to share his screen with us. Dr. Long, on the bottom of the screen, there's the green share screen. Are you able to find that? There we go. Super, over to you.
Distinguished guests, I am Dr. Lam from Quang Hospital for Women and Children, Vietnam. It's my honor to be here today to share our hospital experience to answering the essential newborn care in the context of COVID-19. As you know, Vietnam had a long border with China. The first case was very early, but today we have 0 deaths and no community transmission for over 2 months. Our hospital is in the province bordering with China and near Hanoi, so we were an early hotbed. However, today we have a real IT case. Everything is back to normal. Before the pandemic, our hospital used to be crowded with 8,000 births annually, 52 cesarean sections, and we were the designated Center of Excellence for Breastfeeding by Ministry of Health in December 2019. The whole hospital was fully aware about the importance of breastfeeding, so we met Preemies very early when Vietnam only had 14 cases, and so we can maintain breastfeeding support amid the pandemic. Specifically, we designated 1 separate clinic, 1 labor room, 1 operating room, and 4 postpartum in the Department of Tropical Disease for submitted or confirmed COVID-19 cases. We coach health staff on COVID-19 and ensure to meet the detail at clinics, waiting room to canteen. Any visitor to hospital will routinely screened by body temperature and travel history as a hospital guest. Also, the case self-follow separates good and to clinic and a bathroom. They self-receive RT-PCR test by the hospital and then Center for Disease Control self-confirm after 8 hours. Here a photo of
Dr. Lam, sorry to interrupt you. Is it possible to put your slide on full screen? We are seeing your, no, we are seeing the 2 slides.
Okay.
Yes, that one. I think if you choose hide presenter view.
Sorry, wait a minute.
If you, okay.
Hi, presenter.
Perfect. Thank you so much. Sorry to interrupt.
Okay. Okay. Here are a photo of certificate cesarean section birth with the 37-week swing. After receiving RT-PCR test, she was admitted to separate operating room or have staff put on personal protective equipment the woman on March. We follow normal steps of yearly essential newborn care. Most newborn were in skin-to-skin contact for 19 minutes before waving and vaccination. They had successful initiation of breastfeeding at the 17 and 80 minutes, then transferred to separate postpartum ward with the father. Here, both twins was equitably prepared, with mother wearing masks, washing hands, and wiping surface. The whole family was discharged after 40 days quarantine with a good outcome. Today, we have maintained the full recommended care to all the 56 submitted cases. We even allow birth companion of choice for vaginal birth. And you can see the photo with the husband in Theodore. And we are very happy to see that all other 28 hospitals enrolled in Center of Excellence for Breastfeeding in Vietnam, like us, also maintain breastfeeding and newborn care services. As you can see from the graph, prolonged skin-to-skin contact in the March 2020, the fifth month of COVID-19 in Vietnam would even improve with at 36% comparison with 48% in 2019. It is because the hospital like us are fully aware the importance of breastfeeding, especially in the context of COVID-19. So we try our best to maintain such practice. Thank you and wish you all the best.
Thank you so much, Dr. Long. Thank you for sharing with us the experience from Vietnam, the work that was done to anticipate what was coming and to rearrange your services in a way that would ensure continuity of services and adherence to the global guidance. If you want to stop sharing your screen, we'll let the next presenter bring up their presentation. We're going to move around the world to Latin America. If you'd like to stop sharing your screen, Dr. Long. Thank you. All right, we're going to move around to the other part of the world, to Brazil, and I'm going to hand over to Denise from the Brazilian Parents Preemies Association, who's going to take us through some of the solutions that they have been working on in the Brazilian context. Over to you, Denise.
Let me just check this. Is that okay?
Yeah, if you just want to go into presentation mode.
Okay. So hi, everyone. It's an honor to be here representing Brazil to talk about such an important issue, which is protecting breastfeeding and neonatal services in this context of the pandemics. So I'm going to bring you some numbers on Brazil. We are 211 million people, quite a huge country. We have around 2.8 million babies being born each year, and from this number, 11.5%, around 340,000 of them are preterm. And regarding the pandemics, we have now 1.5 million cases. And if we look at the annual birth number, we can estimate that during the pandemics, the last 4 months, we had around 240,000 new pregnancies. So it's quite a lot as well. When we talk about the prevalence of breastfeeding, Brazil has a lot to be proud of. Of course, there's always room for improvement, but we have 41% of moms who are exclusively breastfeeding their babies up to 6 months. That's a good number. And almost 50% of them are breastfeeding up to 2 years of age of the child. And also we have the biggest human milk banks network in the world. And so we are very proud of that. We have a lot of challenges, of course, as many countries, as a developing country regarding COVID, but 2 of them are very important, which is misinformation, which leads us to low awareness on risks of COVID and low adherence to prevention measures as well. And also we had a previous health system in some regions, especially, that was already in a collapse. So it leads us to a more quicker collapse of services in the context of coronavirus, and also an increase of mothers and infants who are infected. So from the government perspective, the solutions we are looking at now to stop this and protect breastfeeding is setting COVID helplines and online training for healthcare professionals, and also resources, which most of them are based on the WHO recommendations, such as flow charts for services and guidelines, and also this weekly multidisciplinary webinars with experts for all levels of care, trying to clarify doubts from each services. So this is quite a good strategy as well. And we, as an NGO, we are working on COVID broadcast lists, either on WhatsApp and Telegram, and also live interviews with experts to clarify to people, not only to professionals, but to families, online support, free online support for healthcare professionals and families to help them with mental health. And we are also very strong on this zero separation campaign. Only separate mother and baby if it is extremely necessary. And also we have a project called Caring for Caregivers to help families and professionals in their daily routines to help them with mental health as well. And what we've seen as a theory versus practice is that sometimes mothers are afraid of breastfeeding due to COVID and misinformation. Also, some of them have limited access in the NICU. Some services are even stopping mothers from entering the NICU, and we are not judging any services because we have a lot of people going in and out of hospitals and a lot of low-income people with no knowledge about precaution. So it's already happening. Few services stopping mothers from entering just to everyone to be safe. But overall, joint accommodation, skin-to-skin practices, and breastfeeding are being maintained. And also, when we talk about outpatients, we have a lot of big number of missed appointments and even vaccines of these babies after discharge. So this is a challenge for us too, that to say that families should keep that. So just to close my saying that considering that Brazil is a huge country, a developing country, and a continental-sized country, we had already in some regions a poor public health system prior to the pandemics. And considering that, we can say that we are doing quite well. Of course, there is room for improvement always, and these documents, all the flow charts and guidelines are being updated all the time. But we can say that the maternal and neonatal population has low rate of infection, and breastfeeding is being maintained. And this is due to a long time culture of breastfeeding in Brazil, and we have very strict policies on bottle feeding and formula, and this helps us a lot. And just to say that we should keep this close contact with families and healthcare professionals and supporting them, and evaluate case by case, just separating mom and baby if extremely necessary. So this zero separation approach is very important. And also in events such as this, it's very important for us to share information on how breastfeeding and skin-to-skin practices always outweigh the risk for COVID. So thank you to our volunteers and the public that support us. I'm very happy to be here. So thank you all for the opportunity. Thank you, Sheila.
Thank you so much, Denise. It's really heartwarming to hear that, we're hearing in the news all the time about what the situation is in Brazil these days, but then to know that underneath it all, there is so much work that is continuing to happen to ensure that mothers and babies are safe, that breastfeeding continues, that we're doing everything we can. And so it shows that it is possible, right? Even if everybody's talking about the pandemic all the time, it is absolutely possible to make sure that we are still looking after the youngest ones around the world. So we're going to move over to Colombia. Just keep in mind that this is our last presentation before we open up for a discussion. So just a gentle reminder, if you do have a question, pop that into the Q&A box. So we will start taking those questions. You also have the opportunity to vote for questions. So everybody has access to the Q&A box. Feel free to look at it. If there's a question that you really would like to see answered during the Q&A session, do the thumbs up, like it, so that it pops up to the top of our Q&A box, and we'll try and make sure it gets answered. And so we're going to head over to Colombia, learn more about kangaroo mother care and what's being done to ensure adaptations in this time. Over to you, Natalie.
So thank you very much for this invitation. I will try to show you in a few minutes how the Kangaroo mother care programs are working in Colombia in the context of COVID. The same, not going, okay. So the most important thing was a joint consensus in May, April, between the Health Ministry, the Colombian Neonatology Society, and the Canguro Foundation, and recommendation for the Kangaroo mother care programs were published. And these recommendations were updated in June 2020, and we did the bad translation, but if you are in English, if you are interested, you can have them. You have here a map of the 53 Kangaroo mother care program in Colombia, 50 million of inhabitants in Colombia, and 12% of premature and low birth weight deliveries. So we did last week a survey, 42 Kangaroo mother care program answer in 23 cities, and we know that 2 Kangaroo mother care program are not functioning. So we can say that all the professionals nearly read the document and 90% are trying to follow the recommendation. Which recommendation was most difficult to implement? So it was social distancing, coming to the hospital for parents. Only one person can come and grandmother and sibling cannot come. Implementation of telemedicine. For all the staff, personal protective equipment, support for transportation from rural areas, and others recommendations that I listed for people interested. Which recommendation you were not able to implement, we asked. More than 50% implement all the recommendations, the informed consent for telemedicine, the follow-up with all the rules for a Kangaroo mother care program, and the correct use of PPE for the health staff. Kangaroo position and breastfeeding in the NICU was difficult to implement too, because part of the NICU shut the doors to parents, and others recommendations. Which recommendation would you add? Education of parents and staff on the importance of telemedicine, protocol of collaboration between health insurance and programs for transportation, protocol on the necessity to have the parents coming, or one, it can be virtual, the strong support for the vaccination program, protective mask for the babies to come to the program, and domiciliary visit in specific cases. So all the staff have the feeling that they are protecting breastfeeding and mental health of all the family, and 98% are feeling that they are protecting also the attachment and bonding. They 90% were able to have all the protective measures for staff and parents. I have to say that during these 3 months, 3 members of the Kangaroo mother care staff was positive for COVID, 2 for serology, for 2 pediatricians working in 2 places, and 1 for administrative member with a family contact. So the staff believe that when you explain well to parents hygiene measures, they are agreed to carry the baby and to breastfeed the baby. Yes, and 88% were agreed to come to the appointment, and in 10% they did have problem for vaccination. So here I will show you just some photos. That's a 3rd level a unit in a university hospital. So skin-to-skin contact is done as soon as possible and for as long as possible. In case of COVID, so direct breastfeeding or extracted breast milk is a priority, and a member of the family can come and carry the baby while the parents become negative. And 1 member of the staff will be dedicated of the care of this infant with suspected or confirmed breastfeeding. So look at that, we cannot lose that. I mean, and in the ambulatory care program, the rule is protect yourself and protect the others. So we change the space, we modify the space, the working hours. They begin at 6 o'clock in the morning and they up to 5 o'clock. You have your security protocol at entering the program with hand and shoes washing, temperature measures. Everybody's using PPE for the staff. You have protective measures for parents and babies. You have the Kangaroo consultation, as you can see here, the pediatric evaluation, the nursing evaluation. You have lactation support, psychomotor evaluation, even charity groceries for the poorest. So screening for ROP, so important, and audiology. and integration of telemedicine in the follow-up. Strict protocol for disinfection. We are obsessive with that, with a phone, with a stethoscope. So here you have the new look of the Kangaroo staff, for example, in a Kangaroo mother care program in Medellin. Thank you very much. So the goal is to protect yourself and to protect for you and the others. Thank you very much.
Thank you so much, Natalie. It's great to finish with such really heartwarming and pleasant photos like that. I'm going to echo what Maureen said in the chat. I wish this was everywhere. And I think you've shown us that it's possible. It can be done. And that was our goal today, was to really show everybody what the solutions and possibilities are. So we really want to thank very much the presenters, particularly sharing the experiences from Vietnam, from Brazil, and from Colombia, to really share with us what can be done, how we can move forward together. I'm going to invite all the panelists to turn on their cameras now and hand over to Shikufe, who will start taking us through the questions that have come in the Q&A.
Thank you, Sheila, and thank you, everybody. So can we invite all the panelists to turn on their videos? Dr. Long, Jennifer.
You should do for me. I cannot do myself. It's written that the host should do.
Who's speaking?
Ornella.
Ornella, okay. Let me do that for you then.
Okay, thank you.
Wonderful. Are we missing anybody? Ornella, you should be able to turn on your video now.
Excellent.
Okay, bravo. So we have about half an hour for the Q&A, which is, so if you're not speaking, may I request panelists to mute yourself so we don't have the feedback loops? Thank you. So we have half an hour for the Q&A, which is plenty of time for us to get into, and I will invite attendees to also ask questions live. So I'm gonna at this moment lower everybody's hand. And when it's time to ask live, I will invite you to raise your hands as well. Okay, so before we begin, I just want to begin actually with Ornella. Ornella, I see that you've been responding to really great questions in the chat, and I wanted you to just provide a very brief summary of some of the questions you're getting, because you provided in-depth responses to a lot of the participants, and they were really important questions that came up quite a bit. So I'm wondering if you can provide us a couple minutes of a summary of the types of questions you've been responding to in the chat right now.
So we had questions about if it's possible to breastfeed if the mother is COVID positive, and I answer, of course, yes. I think it was very clear from my presentation, but also from the colleagues, from all the presenters in the countries. And then there was a question if we are translating the documents in other languages, we will do. There was a question, I don't remember well the question, sorry.
Yeah.
And then there was a question
Ornella, so I think the key questions that I would love for you to share a summary for, people were asking about transmission of infection between an infected child and a mother, and an infected mother and a child. And there were some great responses that were provided, Ornella. So if you can provide a quick summary to that question.
So there is no, I mean, at the moment, there is no strong evidence about the transmission between both pregnancy as well as during breastfeeding. We don't have, you know, there's been only cases of particle of a virus found in the placenta, and also particle of virus found through PCR in the breast milk, but a not active virus, first of all. And also we know that at the same time, mothers produce antibodies against the coronavirus, and this can be actually protective for the babies. We know also that babies are not affected very much. I mean, young infants are not affected very much by COVID-19. So the few cases that have been positive, found positive, probably contracted the disease after or through a relative or even through a healthcare worker, but in the postnatal period. But at the end, they didn't have a severe disease, you know. So lucky enough, I mean, this age group is not very much affected by COVID-19. While the lack of breastfeeding can be, or even the separation can affect them for the entire life. I mean, it can expose them at high risk of infection, even other infection, not only COVID, but and they can expose them to also psychological, I mean, problems because of not being together.
Thank you, Ornella. And I want to ask Pura as well if you have anything to add and come in, because I know you have been also really active in providing very detailed responses, Pura. So is there anything you would like to add?
Really, just to reiterate that that breastfeeding, skin-to-skin contact is very important in the early months, early years of life. Responsive feeding, responsive caregiving should continue whether there is a suspicion or confirmation of COVID-19 infection in the mother, because breastfeeding, skin-to-skin contact has so many positive effects for the child throughout life.
Thank you. Thank you for that. And another question that we are getting, we're seeing a lot of is concerns about safety and social distancing. So can you quickly just provide, I know that was in the presentation, but I just want to reiterate that because we see so many of those questions being asked is about the safety of the child, about social distancing and what is that. So could we just have, you know, a re-presentation quickly of that, Pura or Ornella, on that question as well? Pura?
Yes, okay. So this question comes up because people are, maybe they're confused or they're afraid, or you know, there's a lot of anxiety, because we tell everyone to keep at least a meter distance from other people, right? We tell that to everyone except to mothers who have infants, who have children who are under their care, because when we look at the balance of the benefits and risks, you know, taking into account that one, the transmission, even the transmission to children is at a very low risk. When they do get infected, for the most part, they get a very mild or asymptomatic illness. Putting that against the benefits that breastfeeding and skin-to-skin contact and responsive caregiving has for the child, the balance is more than 100 times better to continue breastfeeding, to continue skin-to-skin contact, to continue that nurturing care, than to separate the mother from the child, even when the child is suspected or confirmed. So we tell mothers to breastfeed, continue the skin-to-skin contact, to continue that care throughout the illness, throughout the mother's illness. So that is indeed the WHO's recommendation.
Okay, fantastic. Now that we have the basics covered and reiterated, I hope that's clear for everybody. Thank you for that. I have another question here that's again related to safety. It's from Nikki Rose Abrera, who's asking, is it advisable to get pregnant during COVID-19? So do we have a quick question for that, an important question?
Well, I can answer if you like.
Please do.
For the time being, it doesn't look, and now we have many cases, as you can see, there is no, it doesn't look like the risk of COVID, that COVID affects more a woman, especially an healthy woman, compared with the general population. So the problem is if the woman has eventually, as in general, if she has a diabetes or non-communicable diseases, because the fact of having a non-communicable disease, one of those diseases, is a risk factor, an additional risk factor if you get COVID in general. But for the pregnant women don't have an additional risk of a negative outcome for the moment, for what we know at the moment. There are, however, I want to put a consideration of the data we have are based especially on the second and third trimester, because the disease is new and we don't have a lot of data of women who got pregnant since the beginning, you know that. So the first trimester and so we are together, WHO together with many partners now are collecting data and following up cohorts of pregnant women. So it will be possible to assess really in a detailed way all the outcomes for the mother, for the fetus, for the newborn, based also on the COVID status. And so in a few months, I think we will have much more information. But as the data are analyzed routinely, it doesn't look until now that there is an additional risk for either the mother or the baby due to COVID. So, I mean, it's, yeah.
Yes, Natalie, you have your hands up. Yep.
Yeah, I just want to say something on the protection of the baby, because there are questions on that. As we teach the mother the importance to have a mask when she's going out of her house to come to the program, she, of course, she understands that very well, so she wants to protect her baby. So we did not have any problem. We are not, she can do it if she wants, yes? And mothers has imagination and they did beautiful masks and they will put it to the baby just to go out and during transportation and after coming back to the house, they will take it off, and we did not have any problem. So they did some a special visier, or they did mask, and they are feeling really better, and I think it's not a bad idea. It's not a bad idea. We are asking people to come with a mask to the Kangaroo Mother Care program. Yes, and really they can be homemade. Yes, I mean, it's very important. We will not accept somebody without a mask. We will give one if she doesn't have, and we will explain why. So I want to be clear on that.
Thank you, Natalie. That was really helpful. I'm going to ask one of our attendees, Eileen, I hope I'm pronouncing your name correct, Eileen Go, if you can unmute yourself. You have the most popular question in the chat, and if you can let us know where you're calling from, and please, if you can just introduce yourself and share your question with the panelists. Eileen Go, you can unmute yourself. Give you a second. Eileen? Okay, I will ask for you. The most popular question in the chat that is being asked is, how does telemedical consults affect the breastfeeding support that we are providing to mothers, considering that we are discharging them earlier than usual in the COVID context? So if we can hear from the countries, any reflections on that question. So how do we provide telemedical support, distance support? Natalie, please go ahead. Mm-hmm.
Yes, the first appointment, especially when a baby are discharged, a premature low-birth-weight infant, even if they train in the unit, we are not doing virtual. The first appointment are in the program, and the nurse will have gloves. Yeah, she will have gloves for the Kangaroo Mother Care adaptation to breastfeeding, to the position. In this case, we are using gloves, and because it's a big work and it's so important to be successful. So the first appointment are not virtual. If we want to have, at least for premature and low birth weight infant, to have success in the breastfeeding.
Thank you, Natalie. So the first appointment is not virtual, but what about, you know, I guess also I think the question is how do we provide distance support? Because a few of the panelists also mentioned that, you know, mothers are missing their appointments, they're physically not coming in for different reasons. So how are we providing or adjusting and supporting that? Can we hear, do we have from other countries, and then we come back to Natalie? Denise?
Here in Brazil is the same. We cannot make virtual some very important appointments, especially for premature babies that has a lot of, well, they have to be seen for many specialists, and there are a lot of things going on, and we have to look after them, therefore providing quality of life in later life. So, well, it's not happening, these virtual consultations. So I think that what we're trying to do, and the best thing to do, is to give very strong information and recommend for parents that they need to, even with the COVID risks, they have to do all the precaution measures and masks and everything, and go out with the baby, and maybe call the service and arrange a time where it's not so full, and then go there and have the consultation, because it's the best for the baby and for all the breastfeeding process.
Thank you, Denise. Very helpful. Natalie?
No, I just want to add a little thing, which is even people, at least in Colombia, they have, it's not easy, but they have data for WhatsApp. So what we are doing when people are coming, we help them to install Zoom for phone. And we are doing Android, we are doing virtual telemedicine virtual. But for breastfeeding, the first one has to be presential, is what I wanted to say.
Got it. Thank you. Ornella, quickly.
Yeah, just to say that in WHO we recommend actually a virtual consultation for the counseling. So the counseling part can be important for even for routine for healthy babies and of course also for those at higher risk. So we recommend to do that and use also, you know, the all possible platforms to disseminate correct information, because there is also a lot of misinformation regarding COVID and regarding breastfeeding. So both for the breastfeeding counseling as well as for the infection prevention control measures is possible to do through telemedicine as well, not only. Then of course for assessing the baby, it can be done with a consultation that is booked, is scheduled, so there is less risk of overcrowding.
Thank you. So there's a follow-up question on this by Anthony Calibo, who asked, how have the quarantine guidelines affected postnatal care visits, including follow-up care home visits for preterm, small in age and low birth weight babies? Any recommendations? I know you've covered a bit of that right now, but any additional thoughts on that?
It depends a lot on how the country is the health system, how strong the health system of the country and the public health system in particular is in the country, and also on the level of transmission of the COVID disease. Because of course, if there are just sporadic cases, there should not be reason for reduction of access of postnatal care services. But when there is active transmission because of the restriction in movement, the services can be much affected. So what we recommend there is try to have the scheduled visits, give priority to those that are at higher risk, both mothers and babies. Try to have some kind of home visits system, if it's possible, even with the community care workers, and then give some, and then organize catch-up visits. For example, if the first postnatal, so some of the contacts implies missing immunization, then this catch-up immunization visits can be scheduled. So the child that doesn't find is not disadvantaged, basically.
Thank you, Ornella. Thank you. I'm gonna ask Nimat Haji Boy if you can unmute yourself and introduce yourself and briefly ask your question. Nimat Haji Boy.
Hi, can you hear me?
Yes. Can you introduce yourself? Where are you calling from, and then briefly ask a question?
Sure, and I'm calling from India, and I used to be part of the Alive and Thrive group and work closely with Ornella in Vietnam. So nice to see you, Ornella. I'm not sure which question you wanted me to ask, though. I'd posted a couple, and I was actually in the midst of posting a third.
The question I was referring to was your asking about previous pandemics, but if you have a different question, then please go ahead.
Oh, about what have we learned from the HIV/AIDS epidemic?
Yeah. Mm-hmm.
Right. So Ornella, I think particularly for WHO and those on the call, especially Brazil also, who's dealt with Zika previously, I guess questions when we talk about breastfeeding and care of the mother-child dyad is, what have we learned from these past pandemics that are questions that we should learn, that we should really do quick research on and respond to, so that we are, moving forward, we're able to actively or proactively ensure the mother-child dyad stays intact and we're able to provide the best care possible. I mean, the implications that we're seeing right now on what's happening with deliveries in institutions, anecdotal rises in home deliveries, etc. It's leading to some interesting situations. So I'm just curious, especially on the HIV epidemic. Over.
Thank you.
Yeah, thank you, Nimat. Nice to hear your voice after so many years. So yes, we are looking also at previous pandemics and epidemics, and actually we have looked the one where we have found more data that showing an interruption of services or really a reduction in access is Ebola. And it is true that because of fear of getting contracted disease, or also because of the measures that are in place, people are using, have less access to service, but also because the services itself, the health system gets, disrupted. And so it becomes more difficult to, in some countries, particularly those where the health system is less strong, it becomes more difficult to provide both the services for the COVID affected people as well as the routine services. So yeah,
Thank you,
we have
Ornella.
evidence.
Thank you. Can I ask any country responses to this question from Vietnam or Colombia or Brazil? Denise, please go ahead.
Yes, she mentioned the Zika virus, the pandemic. So I think the lessons we have learned from these other situations is that we have built networks, especially in the most affected regions. The government built programs and projects, especially in these regions, the most affected ones, to create this network and to try to release official information and to make this process easier for next epidemics, such as it is happening now. So these are the lessons, like these networks and these programs directing in these most affected areas.
Thank you, Denise. Rick Adrian Villegas, can you introduce yourself, where you're calling from, and very, very briefly answer? We have about 10 minutes left and we want to squeeze in a lot more questions. So if you can just be very brief, thank you.
Okay, good evening. I am Rick Adrian Villegas from the Philippines. Okay, here's my question. Because there is studies right now being conducted regarding COVID transmission. In the event that it can be proven that the COVID-19 can be transmitted via airborne, how can this affect the practice of breastfeeding and newborn care?
Thank you, Rick. An important question. Any responses from our panelists? I know it's a bit speculative, but
it's a special question, but I think it's very theoretical in reality, because we have to base, our practices in what is actually the evidence. So even if it, let's say, is demonstrated it is more airborne than it is at the moment. But we have to look again at the infection rate and the consequences on the babies. And so far, with the millions of cases that we have had, babies, lucky enough, are not very much affected. And we have seen that both those babies who have been separated, I mean, the few babies that got the COVID-19, acquired COVID-19, there was no difference between those who were separated from the mother and those who were not separated, you know, because we have both cases, but with the same incidence of infection and the same, more or less the same outcome. So I don't see, even if it would be declared more airborne than it is, I don't see big difference in recommendations for what concerns the babies.
Thank you, Ornella.
Change in their facilities.
Thank you. I just want to shift gears a little bit now. I feel like we had a lot of intense interest and questions, and I know when everyone registered, you submitted questions, and I want to just share with everyone that we shared all those rich questions with all the panelists, and you know they've reflected that in their presentation, so they weren't gone away. A question I have, especially for our country-based colleagues, Jen, in the Alive and Thrive presentation, she shared a very shocking and important statistic about support for maternal mental health, especially during those separations, and how very little guidelines are there and very little support is there for that. And Jen, I welcome you to, you know, speak on this, say a few words on this as well. So I would love to have country reflections on this very serious issue and how, what are the conversations happening in the countries, what types of support are present in the countries that are present on this call, and reflections on what can be done to strengthen that component of the implementation of the guidelines. So we'll start with Jen, and then we'll get some country reflections on that. Thanks, Jen.
Thanks so much, Shikufe. It's an incredibly important question, and I think a lot of the gaps have to do with just how quickly countries were preparing their guidelines, often without consultation between different departments or different professional medical associations, and with a lack of evidence out there. But that said, it doesn't excuse the fact of leaving this out. And it's an incredibly important component of these guidelines. So I'm looking forward to the experiences from countries and what they're doing on the ground to help moms and infants who are separated.
Yeah, thanks so much for Jen. And I just want to draw our attention to a comment in the chat box as we are speaking about this very important topic. Claire says, heartfelt thanks to this very enriching discussion. I'm a peer counselor in helping out a mother who's COVID positive and was separated from her also COVID positive baby. Mothers have not been consulted whether they want to be separated or not, and that is taking a toll on maternal mental health. And there have been also questions on consulting mothers as well, and how, and on that. So I want to turn to the countries for some reflection on supporting maternal mental health and this whole idea of consulting mothers as well in the development of the guidelines. So any reflections from country colleagues? Maybe from Vietnam, we haven't heard from you, Dr. Long, and then we can go to Brazil and then Colombia. Any thoughts on maternal mental health and what you are observing in Vietnam on the mental health of mothers? Okay, maybe we can start with Denise.
Yeah, I believe that the pandemics made us realize how important this mental health issue is, especially for premature moms and mothers that are going through this all this stress of the coronavirus. But I think it made us realize how important it is to have support groups in the NICUs, for example. And some NICUs, this is a big challenge for us in Brazil. We don't have much support groups in some NICUs, and there is no psychologist in the hospital that can dedicate time only for these mothers. And also for healthcare professionals, because they are working under a lot of pressure now, more than ever. So we are trying to, what we are doing as a parent organization is trying to complement, to help what the government has been doing with all this online training and online support. That's why we have projects that are trying to help with these mental health issues, trying to give online support with psychologists for healthcare professionals and to families as well.
Thank you, Denise. I also want to draw our attention to an example from Philippines. Joyoshti Orbe says in the Philippines, there are peer groups of breastfeeding mothers who are supporting each other through milk bag donors. They call on mothers through Facebook connections and video calls to check on one another. Thank you so much for that example of sharing from the countries. I've just pasted a link to a survey that we are conducting to capture program adaptations. So any innovations, anything you want to share from your countries, please share with us so that we can include you in future webinars, and we can also facilitate learning, because as part of the Nurturing Care Framework Network, we want to learn from countries. Natalie, I go over to you.
No, but I believe that for mental health, it's so important to allow a member of the family to come when they are premature or low birth weight infant, to come to the unit and to carry the baby and to take photo and perhaps video to give to the mother. I mean that for the mother, it's a very big change. She's not feeling that nobody will be with her baby. I think that's very important to carry in kangaroo position, to explain to the baby why the mother is not there. I mean, it's not only the breastfeeding. I really believe that if somebody can come and carry the baby while the mother is negative, because it's 2 weeks. When the mother has the negative PCR, she can 2 times she can come.
Thank you, Natalie. Duong?
Yes. So in Vietnam, like in Quang Ninh Hospital for Women and Children, for the suspected cases, they for vaginal birth, the hospital allowed the birth companion of choice, and it really helped the mothers with the psychological support, and also immediately after the birth, in the cesarean birth, the father or the birth companion of choice also reunite with the mothers and the newborn in the separate postpartum ward. So it really helpful the birth companion and the family members who are admitted to the postpartum would really support the mothers and the newborn psychologically. Besides, the hospital also had the counseling coaching for the health staff in advance about the importance of breastfeeding and how to support the mother to build confidence to continue breastfeeding in the context of COVID-19, whether they are suspected or confirmed. So the health staff is also an important person to provide the psychological support and for both the mothers and the newborns during this time. Yes, so that is the experience from Quang Ninh in Vietnam.
Thank you. I feel like we could go on forever. We have so many questions coming in at the chat and we're right at time, but I do want to take the last 2 minutes. And if we can have, maybe this is ambitious, but if we can just have brief reflections, because I know the country examples were all facility based. And if we can just have really quickly some thoughts about the situation for women who are in, situations where they can't access facilities, especially in rural areas or, for various reasons because of the social distancing and the quarantine, you can't access facility based. Just very brief reflections of what you're observing is the impact that's happening around this situation. If we can just hear from the countries and everyone briefly, we just have a few minutes left in this really rich conversation. So a really rapid round of reflections. Should we start with Brazil? Denise, go for it.
Yes, yes, you mentioned a very big challenge for us, which is the rural areas and the very far places from the main cities and the main hospitals. This is quite a challenge for us because we are a huge country. So the coronavirus hasn't come to these very far away places. So many people don't know about these prevention measures and the risks of COVID. And if they get pregnant, they don't know what to do. So that is a big challenge for us, because the virus is going very slowly through the country. So we are trying to make the information go through more people, as many people as possible. But this is quite a challenge for us. We're still working on this, how to get everyone informed with the right guidelines and where to go if something happens, what services to go through.
Thank you, Denise. Natalie? Do you want to unmute yourself? Yeah.
No, I mean that our big problem was clearly that transportation from the rural part, but we do the same. I mean, we apply the same. 99% of the deliveries are in a hospital in Colombia, so it's a little bit.
That's great. Thank you, Natalie. I just want to note we're getting lots of great examples from the Philippines. Joyce, she says, in the Philippines, there are volunteer riders who deliver milk bags to milk banks and help mothers and babies in their community. That's fantastic. So that's a really helpful example. Again, please share your country examples in the survey that we've been pasting so we can capture all of these great examples. You can complete the link survey multiple times if you have multiple examples. Can we hear quickly from Vietnam about the situation of for women who can't access facilities? You're on mute, Jong. Can you unmute? Yeah.
Yes, can you repeat the question, because my internet was a bit broken.
In Vietnam, what is the situation? How are you addressing reaching women who can't access facilities?
So for the mothers who cannot go to the health facilities, in Vietnam, we during the COVID-19, the maternal and child care, we didn't have any limitation on closing the service for the maternal and newborn care in Vietnam. So the hospital still open and ensure that the mother has the proper and recommended antenatal care and also service. There is some limitation. For example, the private clinic was required to close during the pandemic, and they must and the mother must call for booking prior to the visit. So as you can see from the photo of Quang Hospital, they use the hotline number to ensure the proper booking in advance. And when it comes to the hospital, there's a social distancing in the hospital requirement. And also they classify the patients from the hospital gate to ensure that they are not so that they can classify between the suspected and the not confirmed case.
Thank you. That's really helpful. Okay, Natalie, one last thought. Go for it.
No, just to put the thing as Ornella did. I mean that in Korea, it's 1% of the general population who was positive. So, I mean, in Spain, it seemed that it's 10%. So if you go pregnant woman, it's more little, and pregnant woman positive, it's 15%, so it go more little. So the most important is not to take decision for only a few cases when it can be terrible for all the babies and the mothers. So I believe that it's very important to make the balance.
Right. Thank you for that, Natalie. Okay, with that, we will close this webinar. A big thank you to everyone. Apologies for going a few moments below. I think a lot of great information was shared by all our panelists. It's clear that the situation is varied, but the evidence is clear and the guidelines are clear. So I hope all of you on the call today will take this information and share it as widely as you can through your networks, and keep sharing with us. Share your program examples from the survey. Thank you so much to our colleagues from UNICEF who had to leave early, WHO, our Vietnamese colleagues from Colombia and Brazil. Thank you for the great example, and thank you for the great collaboration, PMNCH. It was a wonderful webinar. The recording will be shared. All the resources will be shared. All the presentations will be shared. You will have everything and more. And hopefully we can keep continuing this dialogue offline, everybody. So again, thank you for your great questions, and stay safe, everyone, and keep promoting breastfeeding. It's clearly important and safe to do so. So thanks, everyone.
Thank you.
Thank you. Bye-bye.
Thanks, everyone.
Thank you, everyone. Goodbye.